Welcome back to Crack the QR series with me, Kavya Tendral. Today we'll be seeing about meningitis and CSF examination in a more easier way. If you have not subscribed our channel, do subscribe for more interesting videos like this and as well press the bell icon so that you will receive a daily video notification. We'll be seeing about meningitis, the causative agents, clinical features, and CSF examination, some radiological investigation in meningitis. Coming to meningitis, meningitis is basically inflammation of the meningeal layer. What is the meninges? Meninges is a membranous covering over the brain and as well the spinal cord. It is from outer to inner, it is dura, arachnoid, and pia in layers. The space which is present above dura is the epidural space, below dura is a subdural space, below arachnoid is the subarachnoid space. The importance of these spaces is in subarachnoid space we have the CSF, in subdural space we have the veins that bridges the sagittal sinus above and the subarachnoid space below, that is the bridging veins. Now coming to the meningitis proper, there is inflammation of meninges, and let us now see some terms related to meninges. See, arachnoid and pia is called as leptomeninges, dura is called as pachymeninges. Pachy means thick, therefore dura is thickest. Coming to other important terms, that is meningismus. Meningismus is where a patient will show signs and symptoms of meningeal irritation, but he will not have actual infection of meninges. This is called as meningismus or pseudomeninges. This is always associated with acute febrile illness or dehydration. So person will show meningeal irritation signs, but it doesn't have actual infection of meninges, meningismus or pseudomeningitis. Coming to the causes of pyogenic meningitis. See, meningitis is pyogenic meningitis and aseptic meningitis. The difference is in aseptic meningitis there is no sepsis, there is no pus cells. Here in pyogenic meningitis there will be pus cell. What is pus cell? A pus cell is basically a neutrophil. So pyogenic meningitis will have neutrophil basically in the CSF. So what are the organism causing pyogenic meningitis? Is basically it is divided into based on the age groups. First is the neonate. Neonate or infants of 0 to 2 months. Let us consider to less than 1 or 2 months. So it is less than. Here the mnemonic to remember is L for Listeria monocytogenes, E for Escherichia coli, and S for Streptococcus group B, and another Escherichia coli is basically we know it as a gram-negative bacilli, and therefore Escherichia coli and other gram-negative bacilli, especially Klebsiella pneumoniae. These are all organisms which is going to cause neonates and infants of less than 1 month meningitis. So less than 1, the mnemonic is less than. Next, 2 to 20 years. Two important organisms we need to remember is one is the Neisseria meningitis, the another is Streptococcus pneumoniae. These two organisms will be coming throughout from 2 years to so on older age. Of these 2 to 20 years, Neisseria meningitis is most common. Now, Haemophilus influenza is another bacteria. It is bacteria. So how to remember is influenza has I is similar to 1, and after 1 year only Haemophilus influenza is causing meningitis. So after 1 year, so like 1 year, 2 year and 20 years, Haemophilus influenza will also cause meningitis. But most common organism is this Neisseria. Neisseria meningitis is most common in 2 to 20 years causing meningitis. Next, coming to more than 20 years, again here is Streptococcus pneumoniae, Neisseria and Haemophilus. But still, more than 20 years in the adulthood, Streptococcus pneumonia will be the most common organism because Streptococcus pneumoniae is a commensal which colonizes the nasopharynx, and it is the time where we go out, we'll be close with relations, and we'll be sharing a lot. So thereby the common commensal nasopharynx can be the most common organism, that is Streptococcus pneumoniae. Coming to other overall, it is most common organism could be Streptococcus pneumonia only. Incidence of H. influenza meningitis has been dramatically decreased because of Haemophilus influenza vaccination. Let us now see the other important conditions where that causes meningitis. So first is post-craniotomy or head injury or CSF rhinorrhea. To remember, post-craniotomy or head injury, everywhere the skull is going to open. So it is like something is breaking and something is going to break down, something is going to enter. So the organism here is Enterobacteriaceae that is going to be responsible in post-craniotomy, head injury or CSF rhinorrhea causing meningitis. Coming to the old age, although the Streptococcus pneumonia and other organism is causing meningitis, there is also Listeria monocytogenes will also cause meningitis. To be noted, it is similar to this organism causing meningitis in infants are less than 1 month of age. Next is post-stent surgery. Again, there is Streptococcus aureus. Another important place where that is Ommaya reservoir. What is Ommaya reservoir is when a person is on intraventricular catheter to deliver the drug to CSF and as well aspirate CSF. This is actually Omaha reservoir. Here we are going to give a catheter from out to in, thereby Staphylococcus aureus, which is a commensal of skin, can cause meningitis. Coming to other causes, that is aseptic meningitis. To remember, in bacteria we have said enterobacteriaceae. In viruses it is the enteroviruses which are most common organism. Other than that, there are other viruses like adeno, rubella, mexo. Okay, so coming to bacteria, one important bacteria, that is Mycobacterium tuberculosis and Treponema pallidum, that is causing syphilis, and Leptospira. These important bacteria are causing aseptic meningitis. Parasite, it is Naegleria fowleri, Acanthamoeba species. These two are free living amoeba, and Toxoplasma gondii. Coming to fungi, it is Cryptococcus neoformans. That is the true fungi. Yeast. So after meningitis, we now coming to the CSF examination. Before that, we need to do lumbar puncture. Here, lumbar puncture can be done in sitting position and in lateral leg position. Ultimately, we need to achieve a maximum spine flexion without respiratory compromise. This is important. In case of infants, on everyone, head and neck should be in neutral position, and it is basically taken, the lumbar puncture is done at not above L2 to L3, right? Because the spinal cord is there. It will be at L3 to L4 and L4 to L5 are sub preferred side. To mark it, here we need to draw a horizontal line on the iliac crest, imaginary line, and then you need to palpate the L4 spinous process, and we need to do a lumbar puncture between the L4 L5 space. After doing lumbar puncture, we need to collect it in three serial tubes. First tube is for chemistry and chemical analysis and immunological study. Second tube is for microbiological examination. Third tube is for cell count and differential count, as well for cytology. Three tubes: one for immunology, chemistry, two for microbiology, and three for cell count, differential, cytology. Whenever we collect it, within 1 hour of collection, it must be reaching the laboratory. One important thing, in case of CSF, we should never refrigerate if we suspect meningococcus and Haemophilus influenza. Never refrigerate the CSF sample, so that if we refrigerate unknowingly, then we are killing the bacteria, and thereby after examining, when we take that refrigerated sample CSF to examine, there will be dead bacteria. Okay, and so we should not refrigerate CSF. Coming to imaging, one should perform imaging for focal neurological findings when we see in the patient, and that to be done, that is a head CT, prior to doing lumbar puncture. Why it should be done prior is to rule out presence of any intracranial lesion, because of it can give a potential risk of herniation by lumbar puncture. In tuberculosis meningitis, the CT shows meningeal enhancement, and there is increasing that is the bulging of this lateral ventricles. That is that person is going to get affected from hydrocephalus. Coming to cytological and biochemical parameters of CSF, very important. Pyogenic meningitis, tuberculosis meningitis, viral meningitis. Coming to CSF pressure, as a basic physics, more the volume, more the pressure. In pyogenic meningitis, there will be more pus cell being produced, and therefore there is elevated more than 180 mm of waters. It is always in 180 mm of waters, not in mercury. Coming to tuberculosis meningitis, it is moderately elevated, whereas it is very still. So it is going this way. Coming to total leukocyte count, total leukocyte count will be more in pyogenic meningitis, and then it will be somewhere around intermediate in tuberculosis meningitis, and viral meningitis is somewhat similar, but more in pyogenic meningitis. Predominant cell type we know in pyogenic meningitis is the pus cell. Pus cell is neutrophil, and other all it is lymphocyte. Because in tuberculosis it shows granuloma. Granuloma is basically because of lymphocyte, and virus also induce only lymphocytosis, and it is lymphocyte. One important thing to notice: predominant cell type is lymphocyte in others, and in normal individual there will be some lymphocyte, and therefore the tuberculosis meningitis and viral meningitis, this lymphocyte is called as lymphocytic pleocytosis. That is, pleocytosis is basically abnormal increase in cells. Now coming to glucose, now as there is many neutrophils getting produced, these many neutrophils to survive, they need energy, and therefore the glucose will be very much less, that is less than 40 in pyogenic meningitis. It is slightly decreased in tuberculosis meningitis and normal in viral meningitis, because we know lymphocytes are basically present normally in the CSF in some amount. Coming to total protein, here there will be increased amount of total protein, again markedly increase in pyogenic meningitis more than 45 mg per deciliter. In tuberculosis meningitis, it is markedly still elevated. That is the reason behind this. Let me say it. And viral meningitis, there will be 20 to 80. That is normal or slightly elevated. In all viral, there will be slightly elevated. The reason for high protein concentration in tuberculosis meningitis is like it is because there is a breach in the blood brain barrier and increased local synthesis of gamma globulins. On clinical examination, neck stiffness. Here the physician is trying to flex the neck, but still the patient is neck is straight. So there is neck stiffness pathognomic for meningitis. Coming to next sign is Kernig sign. K for K. Remember K for knee. So here first we need to flex the knee to 90 degrees and then flex the hip to 90 degrees. And after that, when we try to extend, the person will show say pain or there will be limited extension. That is called Kernig sign. Next is Brzezinski sign. Brzezinski sign. B for B. Remember B for bending of neck. Bending of neck is layman term, or in medical term it is flexion of neck. As the examiner is doing, it is called passive. If the patient is still doing, it is called active, right? So here it is passive flexion of neck we do. Because of passive flexion, there will be elicited hip and knee flexion. This is because there is meningeal irritation, thereby it is a meningeal stretch test. Now quick recap, here the examiner is holding the knee and therefore it is K. So it is Kernig sign. Here the examiner is holding the neck, so it is bending. He said to bend the neck, that is B for Brzezinski sign. Thank you so much for your patient listening.